This e-learning session centres around human factors and non-technical skills and the role they play in patient safety. The session consists of an introductory training package followed by a self-assessment section. There's no pass or fail mark, but the self-assessment section must be completed to obtain a certificate of the completion of training. The learning objectives of this training are to establish an understanding of what the term human factors means and their relevance to patient safety, to introduce the Shell model as a human factors model, to discuss non-technical skills and their relevance to patient safety, to highlight common human factors and non-technical skills issues in managing the deteriorating patient. As we work in a secondary care hospital setting, we're often caring for deteriorating patients. We focus this human factors and non-technical skills training on managing the deteriorating patient, as we've had a number of incidents recently where we had the potential to provide better care to our patients. There are common themes which often arise in providing the best care to patients, and these can be considered under human factors and non-technical skills headings. We'd like to consider the relevance of human factors to how we work and the impact they have in enabling us to provide the best care to patients and optimising patient safety. As healthcare professionals, we want to look after our patients. None of us intend to cause harm, but sometimes a sequence of events occurs which results in an outcome which is detrimental to a patient. If you're a patient seeking healthcare in an acute setting, the risk of an error occurring which results in your death is significant compared to other activities which you might have considered hazardous, such as bungee jumping or mountain climbing. Other industries such as aviation, railway travel and the nuclear industry have a far better safety history than healthcare. The most popular figure relating to patient safety quoted in literature is that approximately 10% of patients experience an inadvertent error in their care during their admission to a hospital in the UK. According to the Health Foundation, this figure probably varies between 3% to 25% of admissions, and about a half to 1/3 of those events are preventable. As well as the unwanted effects on patients and staff that adverse events have, they also have financial implications. This incidence of adverse events results in increased length of hospital stay and a huge financial burden on the NHS, both in the need to provide further care and the cost of litigation which results from adverse events. The vast majority of clinical errors which occur are due to mistakes which have their root cause in human factors. They're rarely technical skills failures. We're highly trained, competently assessed individuals who generally have the technical skills to do the job. Where mistakes are often made is in the non-technical skills, which are rarely discussed or taught, which is why this training package has been assembled. A model which is often referred to when looking at where things go wrong is the Swiss cheese model of accident causation. This model was put together by James Reason, a professor of psychology at Manchester University, and was published in 1990. The concept is that there are multiple layers of defences or barriers, which are represented by slices of cheese in the majority of complex systems, including healthcare. These barriers can either be engineered, such as alarms, physical barriers or automatic cut-offs, or they rely on people and their actions, or they relate to procedures and administrative controls. These layers of defence prevent untoward events from happening. Reason hypothesised that there are 4 failure domains: organisational influences, supervision, preconditions and specific acts resulting in failure. But no system is perfect, so there are holes in the slices of cheese, hence the term Swiss cheese. These holes are continually opening and closing and shifting. The holes represent either active failures, which are unsafe acts performed by people, or latent conditions which may lie dormant in the structure of an organisation and become evident when an incident is investigated. They represent conditions such as understaffing, time pressures, poor design, or unworkable procedures. The presence of a hole in one slice of cheese won't necessarily result in a bad outcome, but when there are multiple holes in multiple layers of defence which line up, then a patient safety incident can occur. If we have an awareness of this concept of multiple layers of defence with holes in them, we can appreciate when the holes are lining up and there is a potential patient safety issue. We have an obligation to make sure our own behaviour is as safe as possible, as we're responsible for the active failures, and we must speak up when we feel that latent conditions are impacting on patient safety. By having an awareness of where patient safety risks come from, we have more chance of preventing harm from coming to our patients. The term human factors is often linked to the term ergonomics, as there is an increasing appreciation of the need for the design of healthcare environments to be based on the people who work in them, rather than the other way round. Ken Catchpole is a professor of human factors and has defined clinical human factors in terms of the effect of all the aspects of our working lives that influence our behaviour and our ability to perform in our roles. When people look at where the risks are in caring for patients, there are recurring themes which arise whether they're looking at hospital care, GP practice, community settings, ambulance services, or mental health environments. All these topics have human factors and non-technical skills aspects at the core of them. If we make a wrong diagnosis of a patient condition because we didn't gather all the information in the first place, or we don't consider the alternative options, we'll deliver the wrong treatment. As human beings, we're not very good at changing our mind once it's made up, so we either ignore information which doesn't fit with our diagnosis, or we'll make subsequent information fit our initial diagnosis. This is referred to as confirmation bias and can be a source of error in treating patients. If we get distracted or can't access clinical information systems, or we can't manage our workload, we may fail to follow up investigations, meaning we don't have all the information we need to treat a patient correctly. Our pathways, protocols, guidelines and algorithms are designed to streamline our thought processes and provide safer, standardised care. But if we don't use these pathways, we're putting our patients at risk. We may fail to recognise that our patients are unwell. Young people in particular may compensate physiologically for a long time before they trigger any scoring systems. And if we don't look at them closely or follow up investigations in a timely manner, we may miss some of the subtle signs that are present. If we get distracted or don't do observations when they're due, we'll miss the fact that our patients are deteriorating. The provision of medical care is complex and involves numerous members of medical teams. To ensure information is passed on, we need to communicate well at handover. SBAR is a recognised handover model and ensures clear communication to describe the current situation and what further treatment is required. If we don't provide clear communication at handover, either written or verbally, we create a risk for subsequent teams looking after the patient and the care they can provide. If our patients are deteriorating, we need to escalate our concerns to those around us who are sharing the care provision. If our seniors are not sharing our mental model or don't seem to be sharing our concerns, then we need to persist in escalating our concerns. This can be difficult, but our priority must be our patient's safety and not whether we worry that we might be wrong or that we might have a disagreement with a more senior member of staff. There are methods of escalating concerns called graded assertiveness, and we'll show you one method of doing this called PACE later in a separate training session. We need to document our decision-making clearly in a patient's notes to enable all of the team members looking after a patient to have clarity as to what the plans are. If we don't document well, there's a risk of vital actions being missed and the potential risk of harm affecting a patient. Due to the pressures of flow of patients through a hospital and the application of external targets, there's a risk that patients get moved on before medical teams have reviewed them or before prescribed treatment has been initiated. And it's important to start treatment as soon as we can, ensure there's a clear handover of any outstanding care which still needs to be delivered. So, we've begun to see where some of the potential patient safety risks may come from in relation to human factors and non-technical skills. Next, we'll look at a human factors model we can use to help us identify where potential risks may arise in relation to patient safety. The Shell model is a conceptual model for human factors that was first used in the aviation industry. It consists of software, hardware, environment and liveware, both central and peripheral. These terms will be explored further in the next few slides. Central liveware refers to the L in the middle of the diagram and represents us as an individual human being interacting with all the elements of our environment that impact on us and how we work. How we interact with each other at the different elements is a fluid state and fluctuates continually. The interactions at these interfaces are an area of vulnerability in our system and are more often the source of error, rather than catastrophic failures of an individual component. Software refers to the non-physical aspects of a system, the guidelines, protocols, pathways and checklists, which we've put in place to keep our patients safe. They need to be fit for purpose and we need to decide to use them. There are often unspoken rules of it's just how it's done around here, which may become a source of error for people who are new to that environment if they're not clearly communicated. Areas of risk may be generated if we don't follow the recommended guidelines or don't put our patients on pathways. Hardware refers to the equipment we use in our working lives. Medical treatment's becoming increasingly complex with the need for more complicated equipment. We need adequate training to be able to use the equipment safely. The training may be difficult to deliver due to time constraints, but we have a responsibility to make sure that we know how the equipment works in our environments. As human beings, we're very adaptive and often don't think about how adaptations of equipment may generate a risk for a patient. If a piece of equipment isn't working, good practice is to report it and to ensure it's available for use for the next person who needs it, as the next time might be 3 o'clock in the morning with an unwell patient. The environment aspect refers to both our working environment and the patient's environment. We all have our familiar areas of work where we feel comfortable. We know where things are kept. We're familiar with the protocols and the pathways for that environment. If we're asked to work somewhere different, there's an immediate risk to patient safety, which we must allow for and be more diligent in checking and communicating with those around us. Our environments can be distracting. If we're interrupted whilst doing important tasks such as a drug round, we're more likely to make mistakes. Pilots operate a sterile cockpit policy, where pilots refrain from non-essential activities during the critical phases of a flight, and we should aim to do the same in healthcare to minimise distraction errors at important points of care delivery. It's important that staff have regular access to food and drink to enable them to work safely. From the patient's aspect, they need to be in the correct environment to receive the care they require. Do they need to be in a monitored bed? Should they be in a level 2 bed? Have we asked for help and referred them on to other teams who have more expertise? We need to be mindful of the potential risk created by treating patients in an inappropriate environment. On a day-to-day basis, we'll have interaction with a number of fellow professionals who make up the teams around us, in addition to patients, their families and carers. These are our peripheral liveware. There may be a hierarchy within these teams which hinders open communication, and we must overcome this by demonstrating good leadership and followership skills. We need to ensure that we can communicate well with each other, assist each other in delivering patient care, and ask for help when it's needed. Central liveware refers to us as individuals in the middle of all these interacting elements. We're fallible human beings, and despite our best efforts, we will make mistakes. To deliver the best care, we need to ensure we always do the best we can for our patients. Always consider what human factors and non-technical skills may have come into play and be influencing how you are delivering care to a patient. A useful approach is to always ask yourself, what might I have missed? If you consider the airport security team when you go on holiday, they'll be looking at thousands of hand luggage bags in a day, but they have to remain vigilant at all times. To help with this, they've been trained to think slightly differently. They've been taught to assume there's a bomb in every bag, and they have to find it. Only when they've excluded the risk of a bomb do they declare, this bag's safe. So how does this relate to our patients? Our patients aren't likely to explode, but there is a potential for an error to have occurred in the care we've provided, which is presenting a risk to the patient. Instead of assuming that everything's okay with our patients and the care we're providing, we could ask the question, what might I have missed? We could identify the areas where risks are more likely to occur. These are the holes in our pieces of cheese. Have we made the correct diagnosis? Have we chased up all the outstanding investigations? Have we put the patient on an appropriate pathway? Is the patient responding to treatment as we would have expected? Could there be something else that we've missed? As we've already discussed, human factors are often at the centre of clinical errors. The shell model is a useful way of looking at where risks may have been generated that could impact on our patient's safety. So far in this session, we've been referring to human factors and non-technical skills. We've discussed the shell model and human factors. So what are non-technical skills? These are the skills which you use as a central liveware in your interactions with all the other human elements around you, but especially in your interactions with the other people you need to work with. They're the cognitive, social and personal resource skills that complement technical skills and contribute to safe and efficient task performance. There are common headings to consider non-technical skills under. The cognitive skills are situation awareness and decision making. The social skills are teamworking, leadership and communication, whilst our personal resource skills enable us to manage stress and cope with fatigue. Considering situation awareness. Put basically, this is the understanding of what's going on. It's about gathering information, interpreting it and anticipating what might happen next. We all see things slightly differently. Looking at the drawing on the left, do you see an old lady or do you see a young woman? When looking after patients, are we sharing our thoughts with those around us? Are we thinking the same thing? Are we sharing our mental models? To be able to know what's going on, we need to have all the information available to us. Letters, notes, results of investigations, observations. When we're looking after sick patients, are we aware of the passage of time? Or are we fixated on a particular task? Have we identified a potential risk? Ask yourself, what might I have missed? To enable us to make the correct decisions about patient care, we need to have assessed a situation, defined a problem, generated a solution, and chosen what we think is the correct course of action. Implemented it and then assessed the response to see if we're on the right track. The more experienced we are, the more we use pattern recognition to make decisions. The more distracted we are, the less time we have to consider options, and the more we rely on automatic processes. This is a fast way of thinking, but it's prone to error or cognitive bias, and we need to be aware of the risks and review our decisions to ensure that we're on the right track. Communication is key to providing safe healthcare in the complex environments we all work in. Communication involves deciding what information you want to send, encode it into words, send those words to a colleague who receive it, and they decode it into meaning. Communication can be one way, such as writing in notes or a letter, or it can be two-way, such as a conversation. The benefit of a two-way conversation is that we can receive feedback and ensure a colleague has understood the information we're hoping to convey, and have the opportunity to ask questions. SBAR is an effective communication tool. We must put information into context, send it clearly and concisely, and actively listen to what people are telling us, and clarify issues which aren't clear. Active listening takes effort, as in general we only listen to about a third of what we're being told, and this is concentrated on the beginning of a conversation. So especially in handovers, we need to ensure we listen to everything we're being told and ask questions without interrupting. Handovers should have appropriate time allowed for them, be formalised in their structure, be free from distraction, and have a recorded element as well as a verbal exchange. Debriefing is a useful exercise to maximise learning from episodes of care and should be standard practice after a clinical day, or a shift has finished, or a theatre list has been completed. Written communication is equally important and must be written legibly, logically, and with a clear course of action.
Oh, hi switchboard, can you put me through to the medical registrar, please? Hi, my name is Hannah. I'm one of the FY1s on call. I'm currently on EAU and have treated an unconscious patient with hypoglycemia, and I'm calling for advice on any further management. Mr. Doe is a 57-year-old gentleman who's been admitted with an AKI, secondary to gastroenteritis. He is an insulin-dependent type 2 diabetic, managed on a bolus basal regime of Nova Rapid and Lantus. When I first arrived, Mr. Doe was unresponsive to voice and required an oropharyngeal airway and 15 litres of oxygen to maintain his oxygen saturations. His BM at this point was 1.9, and I administered a 200 ml bolus of 10% dextrose. On reassessment, his airway is patent and no longer requires an oropharyngeal airway. His oxygen saturations are 98% on 15 litres, chest is clear, heart rate is 80 beats per minute, and blood pressure is 110/80. He is now responsive to voice, and a repeat blood glucose is 4. His pupils are equal and reactive to light, and he is apyrexial. I suspect the cause for this patient's episode of hypoglycemia was due to a drug error, as he received 3 doses of Nova Rapid throughout today, which is double his normal dose. Please could you advise me on any further management for this patient?
The world we work in is complex, and we rarely work alone. The interactions we have with team members are vital to ensure we function well as a team. All the members of a team need to feel valued and able to continue a conversation and contribute to conversations. If there's a lack of respect within a team we work in, we'll not be fostering an environment of open communication. Chris Turner's an ED consultant in Coventry, and he observed how incivil behaviour was impacting on patient safety, and he's launched the Civility Saves Lives campaign. The scientific evidence that a lack of respect, professional courtesy and valuing of team members has a negative impact on how teams function. If we're civil to each other, there are reduced errors, reduced stress and a fostering of excellence in care provision. We don't come to work intending to be rude to people, but we work in stressful environments, and sometimes we might react to others in a way which is unpleasant. It's hard to be polite all of the time, but if we've reacted in a way which may have upset others, it's important we acknowledge this and we apologise to enable us to foster good working relationships. It's important if you've witnessed incivil behaviour that you raise your concerns, so it's not accepted as the norm and we don't have a permissive environment where it's acceptable to be rude to others. Incivility impacts not only on the people who directly receive the rude behaviour, but also on the colleagues who witness it. We're less likely to speak up if we're concerned about how care is being delivered to patients, if there's an atmosphere of incivility, as we may be afraid of the repercussions. So for our teams to work well, we need to be supportive, resolve any conflicts in an amicable way, clearly exchange information and coordinate our activities. A well-functioning team is more effective than the sum of all its members. Have we made it clear to a colleague what we've done in looking after patients and what we need them to do to continue the care? Good leadership is essential to enable us to deliver the best care to our patients. Even the most junior members of teams undertake leadership activities and leadership roles, and requirements will often fluctuate depending on a situation. Good leadership uses authority, but it's not overly assertive. There needs to be a flat hierarchy so that junior members of teams feel enabled to speak up if they have a concern. The leader is a role model for the team and should maintain a high standard of practice as a benchmark for their team. Our priorities need to be based on the best care for our individual patients, which often requires a balance of what we need to do for that patient against the resources we have available, such as adequate staff and the need to meet externally driven targets. There's also a term called followership, which relates to members of teams supporting the leader and not undermining their role. The NHS is a severely stretched organisation, and we will all encounter stress and fatigue associated with this. We need to be able to recognise when this is impacting on our performance and develop short and long-term coping strategies to enable us to deliver the best care to our patients. Try to recognise what it is that's causing you difficulties and ask for help when you need it. As well as recognising the impact of stress and fatigue on ourselves, we should look for it in our colleagues and be supportive of each other. We may have little control over the external stresses we experience, but we have control over our own coping resources and the stresses we cause others. If we're working overnight, there's a natural dip in your performance between 3 o'clock in the morning and 6 o'clock in the morning. We need to be aware that this is when we're more likely to make mistakes, and we should be extra vigilant in asking ourselves the question, what might I have missed? If we have a deteriorating patient in our care, there should only be 3 outcomes for that patient. We either manage them in the current setting with the resources we have available, we ask for further support, such as coronary care, surgical high dependency, medical high dependency or ITU, or we decide with the patient and their family that escalated treatment is not in the patient's best interest, and we make plans for future care based on this decision. If our patients are not responding as we'd expect to the treatment we're providing, we should reassess them and reconsider which of the 3 outcomes are appropriate for this patient. When an inadvertent error has been made in the care we provide to our patients, we need to look at the source of that error and learn from what happened. There are a number of common failings which are seen in a multitude of care settings, whether that's primary care, secondary care or social care. And it's worth considering these common failings when asking ourselves the question, what might I have missed? We need to undertake and document regular observations, especially of deteriorating patients, and not be distracted from doing so. We need to be vigilant at spotting when our patient's clinical condition is changing, especially those at high risk of conditions such as sepsis. We need to communicate clearly, as a large number of errors which occur are due to poor communication. We need to respond to our patients' conditions in a timely manner, which involves skills of leadership and team working. We need to maintain our situation awareness when looking after patients and not falsely reassure ourselves that patients are okay, especially when they're young and may mask some of the clinical signs of being unwell. If we can ensure that we always do the best we can for each individual patient and think which of the human factors and non-technical skills discussed may have impacted on the care we provided, then we're less likely to have either made an error ourselves or have failed to recognise when the holes in pieces of cheese are lining up, and an untoward incident is about to occur. If we can ask ourselves, what might I have missed? Then we're more likely to keep our patients safe. In the NHS, we've focused our attention on avoiding harm by learning from error. As human beings, we tend to look for blame. What happened? Whose fault was it? But things going wrong is at the very edge of our everyday practice, and the vast majority of the time we deliver safe and effective care, and sometimes we deliver fantastic care. We have as much, if not more, to learn from when things go well, and transfer this learning into all areas of our practice. There's also the benefit of improving staff resilience and morale if we move our focus from what goes wrong to what goes right. Human beings are highly adaptive, and it's our constant adaptations which keep our systems safe. This is the role of positive learning, or learning from excellence. To capture positive learning, a positive learning reporting tool has been established in parallel with DATEX reporting. Please submit a report when you've seen either an individual or team go above or beyond what is expected of them in their role, or where a particular pathway or protocol worked well and resulted in a patient receiving excellent care. It would be highly unusual for one individual to be responsible for all the events that led up to a patient experiencing harm while seeking healthcare. We may be one piece of the cheese, but there will be potential holes in all the pieces of cheese around us. But what we can do is understand the risks that our patients are exposed to help us recognise when that specific moment in time is happening. An understanding of human factors and non-technical skills will help you to be able to recognise that specific moment in time. In summary, we are all trying to provide safe care for our patients, but occasionally events line up which result in inadvertent harm affecting patients. If we can ask ourselves, what might I have missed, and think of the human factors model of Shell: software, hardware, environment, central and peripheral liveware, and the non-technical skills of situation awareness, decision-making, communication, teamwork, leadership, coping with stress and managing fatigue, then we may be able to spot that moment in time when an avoidable error is about to happen. We can speak up and keep our patients safe.